Welcome, everyone. We're going to give a couple minutes for the final attendees to sign in. I'm going to give one more minute till we get started. Okay, welcome everyone. I'm Julie Flannery, Senior Regional Resource Director at Caron. Thank you for joining us for our 17th installment in our webinar series, A View from the Mountain, Caron's perspective on addiction treatment in the wake of COVID-19, and today's topic, On the Front Lines of COVID-19, Trauma, PTSD, Mental Health Implications and Solutions. Today's presentation is eligible for 1 hour of social work continuing education credit. We would like to thank our educational sponsor, Jumana Grassi, for assisting in obtaining these credits. Please keep your Zoom session open at the end of the presentation to access the post-event evaluation to obtain your 1 hour credit. In order to receive your credit, you must stay on for the duration of the webinar. A certificate will be emailed to you from Jumana within the next 2 weeks. As a reminder, we will be conducting this session in webinar format. All participant microphones will be muted. During the presentation, please utilize the Q&A feature to ask any questions you may have. Depending on the volume of questions, if we can't get to your question before the end of the hour, we will have someone from our team follow up with you directly. This week, we are welcoming Caron experts to present on today's topic, including Dr. Ramona Roberts, Clinical Supervisor of Trauma Services, John Becker, Director of the First Responders Program, and Dr. Michael McCormick, Medical Director of the Healthcare Professionals Program. Thank you all for joining us today, and I will now turn it over to Dr. Roberts to begin the presentation.
Good morning, everyone. So first, let's just talk about stress and burnout and the body's reaction. So during stress, the body responds by the adrenal glands producing cortisol, adrenaline, and noradrenaline that will help us prepare for action in times of danger, in times when we actually need it. And it can even show up in times of worry. Extreme or prolonged stress, which the COVID situation may be turning into for a lot of us on the front line, it may diminish your body's ability to perform at its typical capacity, which can lead to physical or mental health symptoms, including what we call burnout. Burnout can leave you disinterested with work, restless, tense, forgetful, and having concentration difficulties as well. Those who experience stress on a regular basis are typically capable of shifting to other thoughts, and they're able to relax and enjoy activities as they typically do. They may have some worry, some irritability, some short temper, but to some degree still maintain some feeling of control. For people who have this experience of prolonged stress, that area of control or the perceived control that they have over their life and their surroundings definitely becomes very vulnerable and fragile. So some signs of burnout include difficulty managing emotions or making good decisions. You can go to the next slide, Caitlin. Also problems managing healthy boundaries. For example, taking on too much responsibility. Also, it could be having difficulty leaving work at the end of the day. So you may physically leave work, but mentally you may not be leaving work. You may be bringing your work home with you. You may be interacting with your family members and friends at home, but be focused on the things that were going on throughout your workday. You may also try to step in and control others' lives in some ways. There's also problems in relationships. Some of that can be a result of what I just said, and bringing your work home and how that can impact the dynamics at home. Also physical ailments like aches, pains, illness, accidents, a difficulty feeling connected to what's going on around you and also what's going on within you. There's potentially this loss of meaning and hope for the world and, what's the purpose of life, type of like existential questions that might come up for an individual. And there also may be this difficulty separating clients' experiences or patients' experiences from your own life and from your own experiences with your family and friends. So it's an intra and interpersonal issue that can manifest. As helping professionals, we are a very unique group, right? We are a very specialized group, and helping professionals often experience burnout due to having unmanageable workload or frequent difficult cases. And we're seeing that quite often now during this COVID time. So we have, in terms of the workloads, we have an increase there because we're also dealing with others in our workforce that are maybe impacted by COVID symptoms that need to be out of work, that need to be quarantining. So your typical workload is already heightened from those numbers and those experiences. Working with certain populations can also increase rates of burnout, which in particular is this situation that we're all going through now. For burnout versus vicarious trauma, it's important that we don't confuse these two. So vicarious trauma is not the same as burnout. Burnout is generally something that happens over time, and a change such as time off or a new job can take care of burnout or improve it. For vicarious trauma, however, it is a state of tension and preoccupation of the stories, the traumatic experiences that are shared and described by your clients and your patients. This tension and preoccupation might be experienced by counselors, physicians, nurses, first responders in several ways. We have two there on the slide for you. The first one being avoidance. And this means, so a person experiencing vicarious trauma may avoid talking or thinking about how the trauma affected the client, trying to push it away, trying to ignore it. They may lose sight of what the client had been talking about. They almost try to disconnect in the conversation. And they may feel numb about the traumatic event. The clinician could also be in a persistent state of arousal. So things may impact that clinician more or in different ways than they ordinarily would in having that conversation with that client or that patient or so on. Vicarious trauma is normal and is the process of change that happens because you care about the people you serve, right? All the people that are probably on this webinar are here because you have that aspect within you, right? So just as PTSD is perceived as a normal reaction to an abnormal event, that is a typical line you might hear like trauma providers say, vicarious trauma can be understood as a normal reaction to the stressful experience of helpers who are exposed to traumatic material over and over again. So if we think about these front lines and the type of roles that some of you find yourself in as first responders, as clinicians, as nurses, and so on, you are likely exposed to this material over and over again right now during this pandemic. So we need our empathy when working with other people. We need that, right? That is at our core. And we need that to understand what they're going through, but it can take a lot out of us. And we need time to recharge. If we don't get that recharge, then we can experience vicarious trauma, and it can affect you both professionally and personally. Maybe feeling like you can't do enough, you're avoiding, you're exhausted, you're unable to listen, having some feelings of persecution, guilt, fear, cynicism, addiction show up, hypervigilance, feeling hopeless and helpless, and they can lead you to stop, want to stop doing your job. So we have to take the same advice we give many patients about healthy boundaries. So as a helping professional, you've probably heard people, and you may have used this analogy yourself, but the one of the airplane instruction of put your mask on first, right? Put your oxygen mask on before you help someone else, or you won't be able to give them all you've got. So this means prioritizing self-care, and we have to take care of ourselves because we are the vessel that others are using for help. And I'll come back to that self-care in a little bit. So some of the symptoms of vicarious trauma, some of these look a lot like, you were on the right slide, Caitlin. Some of these look a lot like some PTSD symptoms, right? So someone who's experiencing vicarious trauma can be experiencing any or all of these symptoms, like sleep disturbance, hypervigilance, which is like being easily startled, on edge, hyper aware of your surroundings. Pervasive hopelessness, self-doubt, inability to concentrate, disorientation or forgetfulness, isolation, apathy, anger, just to name several, as you can see them on the slide. Some other symptoms of vicarious trauma are hyperarousal, which can be what we consider like some intrusive symptoms and experiences like nightmares, difficulty concentrating, sleep difficulties. So a helper can also experience these intrusive symptoms much like someone who has PTSD can, and have these repeated thoughts or images regarding the trauma that they hear about or the trauma that they're witnessing there. So we are talking about vicarious trauma, but there's also this aspect during the COVID pandemic of our frontline workers being traumatized themselves. So we can also look at a growth of a PTSD diagnosis out of this pandemic as well in the frontline workers, so not just vicarious trauma. Some behavioral and relationship signs of vicarious trauma. So here we have feeling like you never have time or energy for yourself, feeling disconnected from loved ones, and when you're even when you're communicating with them, like even being present with them, you still feel disconnected. Having increased conflict in relationships, withdrawing yourself from others, experiencing what we call a silencing response, which is finding yourself unable to pay attention to others' distressing stories because they seem overwhelming. They seem incomprehensible, or we direct clients or patients maybe to talk about less distressing material because we can't tolerate it. Other behavioral examples are what we call anhedonia, which is experiencing a decreased interest in activities that used to bring a person pleasure, enjoyment, or relaxation. Maybe they're becoming irritable, intolerant, agitated, impatient, needy, or moody. Some helpers experiencing vicarious trauma also experience an increased dependence on nicotine, alcohol, food, sex, internet, shopping, and you know, that's just to name several, but there's not an exhaustive list there. So some signs from work, humanitarian workers impacted by vicarious trauma are more likely to, and you can go to the next slide, are more likely to make decisions without adequate reflection. They make mistakes. They might take on too much work. They may not be able to fulfill their commitments, take excessive unplanned time off, blame others, devalue or ridicule others, or infect colleagues with their own cynicism, depression, or lack of motivation. Some examples of vicarious trauma are on the next slide. Just some, simple case examples, scenarios here. So maybe a female case manager working with women who have been sexually assaulted. This worker assumes that all the men she encounters are unsafe, making sweeping generalizations about others. A counselor finds himself thinking, yeah, right, whatever, in response to a story told by maybe a friend, maybe it was a client, maybe a colleague, with whom they've always had a trusting relationship. But this is where we see that cynicism, and it may come off as irritability to others. Someone you've supervised for years, maybe they developed a recent habit of checking in with you before making decisions. Maybe they're questioning whether their actions have any value to the clients that they once felt confident working with. So they seem to have lost their sense of competence or confidence in being able to make good decisions to help others. Another example is a social worker whose favorite way to relax is to spend time with their children. So maybe they find themselves wishing that their children would go away and leave them be. So this here would be that example of maybe depression, maybe anhedonia. Or an outreach worker, maybe they're experiencing nightmares about the traumatic experiences of their clients or of their patients, which again we consider to be the intrusive symptoms, the recall, the images, the nightmares, the thoughts about the trauma that's been shared with them. So you may find this happen on occasion, which does not necessarily warrant concern, as it is somewhat natural for our brains to replay events. So you might find that you're at home or you're elsewhere outside of work and your brain goes back to something that you heard at work. But if this is something that is recurring, then you know that maybe you need to take some action and seek some help. Without doing that, we have a high cost, the high cost of ignoring self-care. So the cost of avoiding that care and that help that we need and trying to ignore it as if it will go away can result in helping professionals experiencing things like death anxiety, decreased retention rates of clients showing up, maybe because they aren't able to meet their clients' needs as they once were because of what they're dealing with. Maybe some emotional exhaustion, depersonalization, again, that's that disconnected experience from themselves, reduced feelings of accomplishment, maybe increased use of substances. They can have lower empathy for their clients, and they're 3 times more likely to report physical health complaints. So the cost is there, right? So what can help? What can help us in this situation? One way to minimize the vicarious trauma is to know your ABCs, or what we would call awareness, balance, and connection. Helpers need to take time to self-reflect. Journal writing, therapy, talking with a supervisor or a friend are examples of good habits that build self-awareness. Maintaining healthy boundaries between work and home life is important. Developing non-trauma related interests and hobbies are critical. Learning to relax through meditation, quiet activities, or exercise can be emotionally restorative and help the helper maintain a sense of balance. Having supportive colleagues or peers can help reduce isolation and give opportunities to share feelings or experiences. That can help with that sense of connection, right, in that ABC. It also is it's an important way to develop and nurture trusting relationships. Again, when we see that cynicism start to creep in, this is a way to help combat that, okay? Self-care comes in various forms. You could get a peer support network, create stable personal relationships, and find supervision time. Other ways to engage in self-care are to practice breathing exercises, mindfulness meditations. I also want to make it clear too that mindfulness is not one and the same with meditation. So meditation can be an act that is mindful, right? But there are other ways to be mindful outside of meditation. So for those of you that have this reaction of, oh, I can't handle meditation, my brain doesn't work that way. We have a lot of patients that say that, and we are able to find other ways to be mindful. It just means being present-oriented, here and now, to your present environment. So mindful acts like blowing bubbles, something like that, right? Taking a walk and noticing the colors and naming the colors on your walk of the trees and the flowers that are in front of you, instead of kind of having that tunnel vision walking from point A to point B. As helpers, we must also accept that stress is a part of life and that we cannot help everyone in the way we would hope. Accepting where we have control over things, right? If we think about the serenity prayer that many of you are familiar with, even with our own patients and how we try and help them implement that into their life. And there are areas where they are able to have the perception of control versus areas where they don't, right? Ways that helpers can create good boundaries are to have a ritual that you do before leaving work. For example, some clinicians maybe water their plants or they clean off their desk. Creative scheduling can also help you to set good work-to-home boundaries. For example, making sure you have a transitional activity between work and home, such as calling a friend on your drive home, or maybe you always stop at Wawa for a coffee, something like that. I didn't mean to insert advertisement for Wawa there, but lastly, changing your clothes when arriving home may help you, not just for the germs and what's on your clothing, but to have this physical aspect of changing your place, right? This is actually an area that is missing some attention for those individuals who are working from home as non-essential workers, is where is that boundary between work and my home environment? We must also find ways to take care of our physical bodies, whether that be by fueling our body with nutritious, healthy foods or maintaining an exercise routine. We must find a way to care for our bodies. We can also use instant stress relief techniques like meditation again, stretching, aromatherapy, massages. I even have a pen that I got from a mental health gathering somewhere a while ago, and it has a little massager on the end. While I'm sitting in my office, I can utilize it. Remember that self-care can be as short or long as you want it to be. Some self-care hints are to remember that every little bit counts, okay? So 2 minutes of self-care today is better than no self-care today. We can engage in small self-care moments that help us relax throughout the day. Choose what works for you. Some people like to clean, others like to sleep, others like to be outside, whatever works for you. But it doesn't have to take much time. Even Jon Kabat-Zinn, if you watch any of his mindfulness videos, will explain that it's more of a way of being rather than doing. You can take self-care while you're driving in your car. You can be mindful, paying attention to the things you're driving by in your car. So mindfulness doesn't have to be carved out into like this 20-minute period, because right now that is something that we are lacking, is a lot of time that we have for ourselves. Find a way to laugh, stretch. Humor goes a long way for self-care. Maybe it's watching a funny show or a funny video. In the middle of your day, pull up a funny YouTube video that makes you crack up. So grounding techniques would be a very easy go-to, and that again is paying very intentional, that sounds kind of redundant there, but paying attention to your environment, very focused, very specifically to the details in your environment to bring you to present here and now focus. All right, so I will pass it over.
Thank you, Dr. Roberts. And I would like to say, and thank you all for being on here with us, that we certainly are facing a crisis right now amongst our healthcare workers, and it's a real thing. We see it on a daily basis. Our patient count has certainly increased, and the severity of all of their illnesses has also increased. And a lot of it over the last 4 to 5 months has been directly related to the COVID and what it's caused with them in their work and in their home lives as well. So some of the things that when we talk about factors that affect healthcare workers, mental health workers, substance use, mental health disorders, some of the common things that we're seeing over and over again certainly is are working longer shifts, are staying later and longer to help in taking care of these patients, and it is increasing their stress quite a bit. One of the things that we hear over and over again as well is the fear. A lot of this is really based on fear. And that's as simple as, will the patients expose me to the virus or will I get the virus from them? You hear the stories on the news of healthcare workers that have been infected with the virus, and, not all of them have survived that. When you talk about, and John will get into that, the people that go into, whether it's as a policeman or in the military, they certainly know that when they go on their shift, there's always the slight chance that they won't return home. That's a very severe thing, but that's kind of transition that we've seen to the physicians, nurses, dentists, and everyone in between that takes care of these patients. Kind of an offshoot of that we've heard as well is the real fear: will I bring this home and will I pass it on to my loved ones? So again, we've heard on the news situations where, a healthcare worker will try to isolate themselves or quarantine themselves completely in a different part of the house or in a completely different place and stay there because of their, concerns that they don't want to give it to their wives, husbands, partners, children. Parents may be in the house, and that's a real thing that people are feeling. We talk about it being an invisible virus, and that's very, very worrisome to us. Many times we kind of know, okay, here's what we're dealing with, and we're able to take that head on. And really, I think that fear is probably the most severe thing that we're seeing. Another thing that we're also experiencing is the financial stress. And that has affected a lot of healthcare workers. So some people have been, furloughed or laid off. And then, you always talk about when we get a job, our parents and our family and everybody always says, well, you always have a job. Well, that's not true with this pandemic. And that starts with, we saw it with dentist offices. So we've seen dentists and we've seen, dental hygienists and people that work in the office that have been laid off and haven't worked for that period of time. Certainly see it in a lot of the specialties that don't, are more of a one-off. So an orthopedic surgeon, or even we had a cardiologist, people that aren't necessarily, directly taking care of these patients. And when you cancel all elective surgeries, that affects a large amount of operating room nurses and operating room techs and the staff out front who are organizing it. So there's been a lot of that. And there has been not only that, but there's been a decrease in pay that we've seen. So a lot of practices have been down, upwards of 50 to 75% down in revenue. And that's a significant amount. So people that have been more well-established, we've seen that they've taken significant pay cuts, and they've tried to help those that are more of the support staff to keep them with their money coming in, and some of the younger physicians, but it has affected them and they have work. And some of these offices and practices won't come back because they've been hurt so much by this. So that financial stress, look, everyone on this call and everyone on this panel knows what that financial stress is, and it can be extremely heavy for people. And if we're living at one point where we're just getting by and we're surviving, and then you throw this at us, that's a very big deal. And we've seen that, and the patients have discussed that with us. When we talk about the dread, and that's the uncertainty. That's really, when will this virus leave us? And that's a big thing. And I don't know, maybe someone on here has that answer. Share it with us, but we just don't know. Getting into June, and then of course has come back up, and we're seeing that the mortality from it. But I really don't see it is with our patients. Some who work in hospitals say, well, we had 2 floors that turned into just COVID floors, and now we're down to one part of one floor, and that's just our basically our our unofficial explanation of what's going on. So what are some of the indications that there is a problem? Well, one of them is that there certainly can be mood changes that we see with people. And that may be that anxiety, that fear, that short-tempered and everything in between there. There certainly can be increasing depression. Sleep has been a big problem for patients. That's what we've seen the most, is that they've been unable to sleep. And just malaise, generalized malaise for our healthcare workers and how they've been with their families. These things all lead to increased substance use, unfortunately. Certainly malaise is a big one. Tendency to isolate, trying to deal with the stress in unhealthy ways is what then occurs there. And what does that mean? Well, it's going to increase their drinking or substance use or other behaviors that are very worrisome for us. We have examples of physicians who probably had an underlying drinking disorder, who then weren't working. They start to feel the stress and the anxiety of not working, the financial parts of that. And then all of a sudden they start to drink a little earlier in the day. And then next thing you know, they're drinking all day. And that's what's occurred. And we have seen that. Another interesting thing, which is, scary, but it's true, is we've had some, it's more in the therapy world, who, we used to go into an office and see patients, and, there's some accountability obviously there, but now they're seeing patients at home from Zoom. And so they see a few patients in the morning, and then they go and have lunch and may have a drink or two or use a different substance, and then see patients in the afternoon. So that's obviously extremely scary for us, for the public. And, thankfully, those several patients got to us and are back on the road to recovery, which is great. The drinking or using, regardless to the consequences to health, the livelihood, or their family, that's addiction, right? So when the wheels are off and there's just really no accountability, there's no leverage, and the person is just using, that's when the substance use has moved along to a point where there's not much that can be done other than treatment, adequate treatment, and then transitioning someone into a 12-step recovery program and a monitoring board, and get them back to their regular lives. So when we talk about the stigma or the seeking help, a lot of healthcare workers have been taught that there is a job to do, so you have to do it. There's no questions asked, you just do the job, right? So that's what this is in front of us, so we get to it and we take care of it. It's as simple as that. Whether it's right, wrong, or indifferent, there is a stigma around asking for help. And that's the absolute wrong thing to do, especially in this time that we're in. These healthcare workers have to ask for help. And it's hard to do, right? Because what do they see it as? Well, they see it as a sign of weakness. And we know that it's actually really a sign of strength. We had a patient who works in a healthcare system who was having a very difficult time. So she was working all day as a healthcare provider, taking care of COVID patients. And this is just a common story that we've heard. And so I think it's very beneficial for you to hear and how it turned out for her. She would come home from work then, a lot of stress, a lot of anxiety, afraid that she was going to spread COVID. She didn't know that she did or didn't have it, to her husband. And she had a child at home, a younger child. And she would then make dinner and then turn on the news. And she got into that cycle where she was dealing with it all day, and then she was starting to hear the news. And this was early on in March when there was, so much media attention around it, which was very difficult. And it affected her negatively, like you wouldn't believe, because then she perseverated about it, was sleeping pretty much never, and her drinking just skyrocketed. Yes, she had an underlying alcohol use disorder, but it worsened it. So what happened with her was, truly, we think it was a blessing, and she saw that by the end. They have a system in her hospital system. It's kind of and some may understand this or know it, it's kind of an overall message system where a text alert goes out to everyone in the hospital system. So one night when she was, her drinking was towards the end, she reached out and she thought she was texting her supervising physician. And she said, "I need help." So she texted him that. And shortly thereafter, this was around 3 or 4 in the morning, around 6 or 7, her phone just completely exploded because she had mistakenly sent it out to the whole hospital system. And so obviously everyone on this call probably cringes because they thought, oh my goodness. Now actually, it will help her in the long run, because now she doesn't need to, explain to anyone what's going on. And if you think that everyone in that system that received that message wasn't going through similar things, or a majority or a fair amount weren't, she probably helped others who were able then to ask for help. Sure, she was certainly embarrassed, for a period of time, but she worked through that because she knew that she needed the help around her mental health, and she needed the help around her substance use. And she got here. Yeah, obviously that's not ideal to have all those people know it, but that's how it occurred for her. And she was able to get through that and to work through that. Certainly, we know that most systems, most offices, most hospitals have, an employee assistance program, which are, so valuable during these times. And everyone needs to utilize them. We need to talk to a counselor. We need to talk to someone about what's going on. We need to tell them, hey, this is what I'm dealing with, and use the resources that they have available to them. On a higher level, we deal with, certainly a lot of physicians and veterinarians and dentists, and nurses as well. So we know that, and we know, each state has a different physician's health program or nurse peer assistance program. In the state of PA, we have a very strong Pennsylvania Physicians Health Program and a very strong Nurses Association. The PNAP is what it's called. You have to reach out to them. They want to help people right now. They always want to help people, but certainly in this time, they realize it. Their numbers, their calls are all very much up, because we speak to them on a daily basis. And so someone has to have that ability to call them and to share what's going on with them. Yeah, of course, they're fearful of what will happen. Well, you know what? It's, if you continue on the road that you're going, something bad is going to happen, and it's going to be figured out, unfortunately. So the best thing to do is to reach out to them. Although people are nervous about that, they worry about their careers, you have to do it. It's really vital, and it's very hard to make that call, but you'll see how receptive they are, to that person. And really, I know we have people probably from all over the country, just a quick search. If you don't know who those organizations are, you can search that, through Google. We certainly have that list. Happy to send that out to anyone around the country, and then have that availability to give that number to healthcare providers. And each one in each state kind of monitors different people, whether physicians or therapists or, nurse practitioners or physician's assistants. It can be a little different, so we can help navigate that for you. What do we have here at Caron? Well, we do have a standalone, and we have for, 4 or 5 years, a healthcare professionals program. We feel like, and we know that the disease is no different amongst anyone on our campus. However, there are really particular things that we address with the healthcare providers, because it's helping the helper, right? That's what we're doing. And so there are specific questions, issues that come up. We've had an unbelievable response to our healthcare program. All of our patients, have been extremely happy that they were in that environment, because it is a little bit different. Just like, that John will talk about the first responders. It's Caron's foresight and staying ahead, really, and being the thought leaders in this world, that we're able to have such a program. And there's not many of us around the country that do this. and do it the right way. So we're very proud of our team, over 50 years of experience dealing with healthcare professionals. Dr. Gable, who was the director before me, actually began the Pennsylvania Physicians Health Program. So we have that side of it as well as now, and then moved over to the treating side. And we are in a phase system. It's clinically driven, and it's a variable length of stay, typically a 6-week length of stay, but that is variable depending on where you're coming from and a lot of other factors. But it's more of it as you attain different levels and as you progress along, that's where you would move forward. We do have complex co-occurring issues. So when I started here at Caron 5 or 6 years ago, I think we used to quote 66% or 67% had co-occurring disorders. I think now it's in the high 80s, and that's just a sign of the time, our ability to diagnose that and to take care of those patients. So when we have a patient come in who, and I know it sounds funny, but just is, straightforward alcohol use disorder and opioid use disorder and doesn't have these co-occurring issues, it's more of the minority. So we're set up for that. On our unit, we have a psychologist, Dr. Santoro, who's fantastic. We have Dr. Scioli, who's our psychiatrist. But it's from the top down. It's everyone is involved in the care of these patients because you have to look at the whole thing. And that's really what we're seeing. When we talk about why it is a little different for healthcare professionals, it is because there can be licensure and work issues. That can be as simple as when you come back to the cath lab and you're working and on, 3 days into it, and one of the techs says to you, "How are you doing?" It could be as simple as that, or "Where have you been?" And we're able to help them with that. We're able to help them with patients who may say, "How have you been, doc? Where have you been?" We're able to help address that and how they handle that. And the truth is that they're going to be better healthcare professionals for going through this, taking care of themselves, taking care of the problem that was there. Licensure, certainly we help them navigate that. And, when we're in a tough time, it's been an interesting time, certainly in the state of Pennsylvania over the last 3 to 4 years from a licensure standpoint and what that means with certain events that have occurred. So what that person has done or hasn't done, whether it's diversion or whether it's, writing scripts or whether it's a DUI, there's a lot of nuances to that. So we help them and support them through that process, which is vital because we want to deliver a better mom, dad, husband, wife, father, son, brother back. That's what we want. We want people to be in recovery and be all of those things, but we certainly want to deliver people back to work and to continue to be a great nurse or great therapist, a great dentist, a great veterinarian. And that's really what it all comes down to. Is this patient population difficult? Yes. So, we have there on the slide about seeking and accepting direction from others. So we do have all the answers, right? We know that we treat people. We know what this disease is about. So yes, it can be a difficult patient, but that's what we're set up to take care of and to help. So we're certainly, aware of that and to try to take the frontal brain out. People say to us, "I got this. I understand now I can't drink again." Well, it's just not that simple. And when we're in a safety sensitive profession, which is what we all are, it's a different ball game, right? So pilots and healthcare workers are different. It's just the way it is. And it's just that we have to put that stamp and say, this person is okay to go back and practice and take care of our families. That's really what it comes down to. We do help them with that transition back, to their professional practice and how to navigate that from, like I said about whether getting back with partners or back into a hospital setting, in the shame and the humiliation or the embarrassment that they may be feeling, which we help them overcome, I think is very important. And part of our specialized program, we have 3 groups that really are very helpful, we believe, with the healthcare professionals. The first is the caduceus group. So we introduce them rather quickly into that. And that's a specialized, it's not an AA meeting, but it's based very much on that around healthcare workers. And so there are common things talked about in those meetings, and that when they return to their homes, they'll certainly continue those meetings, which are great. The Enneagram is extremely interesting. Dr. Gable started that about 3 or 4 years ago, and it looks at really basic personality types, and the patients buy into it. There's no, it transcends everything, age, gender, religion, whatever it may be. There's 1 through 9, and the patients really enjoy the process of determining whether they're a 1 or a 7 or a 9. And then it helps them to have better insight into themselves and allows them to get better, we think, because that's really the way to look at that from a thinking, a feeling, and acting standpoint. So very, very beneficial for our patients. We've noticed that. I know it'll be talked about, but the stress relief for healthcare professionals, the last slide there, we certainly acknowledge, we understand the feelings of grief, anger, anxiety, fear, depression, and everything in between. And we try to help them manage those emotions in a healthy and constructive way. And that's been referred to and will be again, mindfulness and really we break it down, and I'm sorry, but it's the right things. It's proper sleep, it's eating well, it's, exercising, which has been difficult, right? We've had that with certain patients that the gyms closed down and it affected them. So we talk about getting outside, yet still social distancing. All of those things are important, and having outlets and helping them to see what those outlets are in their specific community going forward. The connection with the healthcare providers, that's so important. And so we do help to bridge people with that. And that's so important in your communities, that you show these patients, really other healthcare providers, that there are others out there like them. That's the biggest thing. There are so many people that have been affected by this. We have really seen it here on our campus. It's been very, very apparent. And it's scary. And we know that the next 6 months are going to continue, could be longer than that we're going to see more and more, because there are people out there, in pain and in suffering from this disease and from the mental health. And it's a scary thing for us. Certainly there are chat rooms. The AMA has one, the AOA has one, resource pages, they can find all of that through American College of Physicians or through the different nurses organizations. It's certainly out there. They do have to do some work with that. But if they make the effort, then it's going to turn out well. But we do just want you to hear, and I know you all know this, that's why you're on, that this is a crisis for us right now. We are seeing this, on a daily basis, and it really, really has affected our healthcare workers, which is everyone that's on this call. And it's a scary thing. We really need to look out for each other and help each other through this time. So with that, I thank you very much for listening, and I'm going to pass on to John.
Thanks, Dr. McCormick. Good morning, everybody. Welcome. We really appreciate you coming out this morning. I'm going to talk a little bit about the first responder population and how COVID-19 is impacting them. When we talk about first responders, we're talking about police, fire, EMS, corrections officers, probation, military folks, both active, retired, civil service, civilian soldiers, sorry. So they're all part of the group that we work with. And so we talk about what bothers them. And the list that I have on the screen is generally the big traumatic events that first responders experience on a regular basis. The things that we could probably all agree would bother anyone, right? Abuse or death of a child, dealing with, suicide scenes, sexual assaults, things like that, homicide scenes. They're going to elicit a reaction from just about anyone that experiences them. First responders deal with that on a daily basis. Next slide, please. What we don't often think about is the other things that bother a first responder. Insult, harassment, and humiliation from peers, community, media, things like that. They're being judged for actions, or just, kind of natural going back and forth between colleagues and peers. These folks are human beings. They have feelings, and sometimes things that are said or done impact them. What we often don't think about too with first responders is, it's their job to help. And when they get placed in a situation where they can't do that, they begin to feel helpless. And that really, impacts them, that they're not able to help somebody, maybe a fire where they're not able to get in and rescue someone. The futility of it all, you often hear first responders say, I don't know why I keep doing this, go back for the same thing, and it's thankless, and it often is. Those jobs are often thankless. We don't always see what they do on a daily basis, and sometimes it feels, almost like it's futile for them. The final thing that we're not really often pay attention to that is a stressor, but when you ask a first responder, and that's across all disciplines and anywhere in the country, what's one of your top stressors, they will tell you it's the administration, it's the agency. A lot of times they'll say, I could deal with the public, but my bosses stress me out. That's universal. It's just part of the dynamic of being a first responder, but it's legitimate. It's real for these men and women. Next slide, please, Katie. So in a first responder, stress tends to present a little differently than maybe in your average person. First responders are natural crisis managers. When things happen, they jump in, they manage it, they handle major things very well. They go from call to call, taking care of a problem, moving on to the next one. Very good at crisis management. When they're struggling, where their struggles show up is in the day-to-day activities, the mundane stuff, chores, bill paying, going to family events, socialization. They tend to, isolate and step back from social activities. So it doesn't show up necessarily right away in their work performance. It shows up in other areas in their personal life. Next slide, please. So first responders, I've stolen this chart from Kevin Gilmartin, who wrote a book about hypervigilance and emotional wellness for law enforcement. And basically what it shows is a first responder goes to work and they're on duty. They're alert, they're energetic, they're upbeat, they're out there doing their thing. When they get home, they don't normally return right back to a normal range. They end up crashing, right? After a 12-hour shift, they come home and all they want to do is sit on the couch and stare at the TV or veg out playing video games. That's often seen as them being tired, detached, apathetic, things like that. And to a certain extent it is, but it's that natural cycle of hypervigilance, being up at work and they need to cycle back into a normal range. Unfortunately, most first responders don't have 18 to 24 hours off in between their shifts for that range, for that cycle to take place. So what ends up happening is they ride a roller coaster up and down, from being up at work and down at home. And that leads to a lot of issues, both personal and work related. Next slide, please. One of those problems, substance abuse. Some information out there, first responders, 25 to 30% of law enforcement reports abusing alcohol, 20% lifetime adverse effects. Volunteer firefighters, approximately 50 reported binge drinking, and 50% reported binge drinking. So it's an established problem within the first responder community. And if you look at statistics from any of those professions, they're elevated, often 2-3 times what you'll find in the regular population. Next slide, please. So what do we know about first responders? First responders are control freaks. They love to be in control, and they're very slow and reluctant to trust anyone. And like Dr. McCormick said, with healthcare professionals, admitting they need help means they're not in control, right? That's a sign of weakness in their minds. There's a fear that they're going to be judged as weak or broken if they can't handle this, because we expect our first responders to handle everything. So sometimes what we see with that is it presents as anger, but it's really fear. On the outside, when they come into us for treatment, there's a lot of anger around everything. And really what it is, it's fear, and getting them to see that they're fearful about what's going to happen to them. They're fearful about their drinking. They're fearful about how they're feeling, their anxiety, their depression, things like that. And that's where we can really start to do some work with them. Next slide. So when we're dealing with first responders, there's some inherent barriers to helping them. They deal with stress on a daily basis, and they've developed skills to be resilient. Those skills have served them well, whether it's for 5 years, 10 years, or 20 years. that doesn't mean those skills are healthy, right? They work sometimes. They work until they don't work. So they've built resilience through the course of their professions. So we have to overcome that and redirect that resilience in a healthy way. Being a hero and willing to be emotionally vulnerable, right? You know, strong alpha personalities don't like to be vulnerable, don't like to talk about emotions. So it's really hard to work with this population. You got to overcome that barrier. A lot of first responders, you ask them who they are, their first response is, I'm a police officer, I'm a fireman. Now they may be married, they may have children, but the first thing they'll tell you about themselves is their job, right? That's how strongly they identify with that profession. It's more than just a job. So we have to help them kind of balance that work, home, relationship, so that they're not so hyper-focused on being a police officer, being a fireman. So it's a balancing act, and that's a barrier to treatment often. Next slide, please. So what do we know? In working with first responders, it's really important to create a safe environment where they feel that they can talk about their feelings and their thoughts without judgment, without repercussions, things like that. Most first responders, inherently are distrustful of mental health professionals because if I tell you what I'm thinking, you're going to take me off the street. You're not going to let me do my job, that kind of thing. So it's important to make them feel safe and to a point where they'll open up and talk about what's really going on and not just stay on the superficial. First responders, things like traditions, symbols, the ideals are very important. So an environment where they feel that they're part of a community and supporting those values and ideals is very important. The key to working with first responders is to build upon the natural social bonding that takes place among first responders. Police, fire, EMS have a lot of shared cultural norms. So when you put those folks together, there's a natural bonding that takes place, and that serves as a protective factor. Next slide. So when we're talking about actually treating a first responder, as we talked about creating a safe environment, confidentiality is key, whether it's residential, outpatient, or somebody just coming to you asking for advice. If they don't feel they can trust that what they're saying stays between you, you've lost them. It is so very important. Peer approach is the key. First responders will trust other first responders long before they'll trust a civilian or a mental health professional. It's just inherent. They have to rely on each other for their lives. So trusting them with their thoughts and feelings goes hand in hand sometimes. We want to help them reconnect with the sense of family and not solely identify as their job. Being able to talk about their feelings, thoughts, and behaviors, and also get them to recognize, to see that trauma has impacted them. Many of our first responders that come into treatment will tell you they don't have any trauma issues. And the reality is that they do, they're just not aware of it. They've kind of put it away or thought they put it away until it starts to come out sideways on them. So trauma is a very big part of SUD among first responders. First responders, when you talk to them when they're struggling, they tend to focus on the negative and negative about everything. So shifting them to see more positives in things. And part of that comes with the job, right? If I'm a police officer, I deal with 10% of the community on a regular basis, but that's 100% of the problems in my community, right? So my view of the world gets skewed a little bit. Most people see the world as a relatively safe place, where first responders, police in particular, see it as a dangerous place because to them it is until they prove it's not, right? And it's important to provide ongoing services. Long-term treatment, regardless of what the setting is so important in helping first responders get back on track. And continued peer involvement. I can't stress that enough. The peer connection is what really breaks down the barriers, and they not only support each other, but they can challenge each other in ways that clinicians or mental health professionals can't. So it's a very good dynamic that we try to continue post-treatment as well. So in kind of wrapping up, the next slide, I think that's it for me, right? Yeah. So wrapping up with first responders, I just want to say it's a difficult population to treat, but the key is to provide them services in a safe environment, no matter what the setting is, and to make it safe for them to open up. So thank you so much. Julie, back to you.
Julie, unmute yourself.
Sorry about that. I was thanking our presenters and reminding them that we're offering a continuing education credit for social workers. A survey will be posted for you to take immediately following this presentation in order to obtain your credit. Again, you must have been on for the duration of the presentation to get the credit. You will receive a certificate of completion in the next 2 weeks. Please join us next Tuesday, August 4th for our next presentation on trauma, addiction, and post-traumatic growth. We will welcome a guest speaker, Dr. Scott Giacomucci, Director and Founder of the Phoenix Center for Experiential Trauma Therapy. And please watch your email for details on how to register. Please reach out to your local regional resource director at any time for additional information, resources in your area, or questions regarding admissions to any of Caron's programs. Our residential campuses in both Pennsylvania and Florida are open and ready to provide world-class care for those suffering with substance use disorder and mental health issues. We have had zero community spread of COVID-19 at any of our sites. Additionally, many services at our regional recovery centers have gone virtual but continue to provide outpatient, intensive outpatient, and evaluations via telehealth. We look forward to seeing you in person. Please visit caron.org or contact your local regional resource director for the latest on our response to the COVID epidemic and to ensure patients remain safe and healthy while receiving the utmost quality of care. Thank you for joining us and have a great afternoon.